Thank you very much. And thanks again for the invitation to talk. I found this a very stimulating, excellent, intimate meeting. So I'm going to present a lot of randomized data actually informing the role of radiation and hormone therapy in advanced prostate cancer, though still that doesn't mean that it's necessarily changed practice. I think it's an interesting follow to the prior presentation. So this will make that point. If we look at trends in practice patterns in the US, specifically the CAPTURE database, which captures a lot of urologic practice in California. CAPRA, this is the equivalent of low risk, intermediate risk, high risk disease. So let's focus on the high risk group. And what you'll notice over the years from 1990 through 2007, that in high-risk disease, external beam radiation was only being used 14% of the time. Primary androgen deprivation therapy was being used 46% of the time. And indeed, over those years, there was a trend in a decrease in the use of external beam radiation and a very complementary increase in the use of primary androgen deprivation. And the question is this evidence-based practice behavior? So I showed some of this data yesterday, but the question is, does radiation in fact work? And the answer is a resounding yes. We have two large randomized controlled trials, both published in The Lancet in recent years, proving this point. The first was Vidmark in the Scandinavian randomized trial in locally advanced and high-risk disease, randomizing to the use of hormone therapy, LHRH agonist-based, or hormone therapy alone, or external beam radiation plus hormones. And indeed, there was a whopping benefit in the avoidance of PSA recurrence by adding on radiation to androgen deprivation. And there were very clear and significant survival gains, both in cancer-specific and overall survival at 10 years, and no meaningful quality of life disadvantage to the addition of external beam to hormone therapy. A very similar trial, an intergroup trial, has also recently been published, again in high risk and locally advanced disease, randomized to continuous androgen deprivation alone or androgen deprivation plus radiation. And very similar results. Clear overall survival benefits to the addition of radiation, number needed to treat of 17, which is excellent in oncology. And similarly, disease-specific survival gains to the addition of radiation, a number needed to treat of only 9 to save 1 life from prostate cancer. And similarly, this was well tolerated. Toxicity profiles were favorable. Yes, there was some decrement at 6 months, but by 2 years, quality of life in the bowel domain, for example, was equivalent. So no long-term meaningful decrements due to radiation. So that's pretty powerful data. In fact, it's level one evidence supporting the combination combined modality therapy. Indeed, there is no real other comparative level 1 evidence in that disease setting. So we'll get back to that a little later. But let's talk about androgen deprivation, because this is also an area of a lot of randomized data. This is sort of a summary. When the local control with radiation is presumed to be good, we don't use hormones. When the risk of local failure is high, short course. And when the risk of distant disease is high, such as advanced disease, it's more like 2 to 3 years. There are biological advantages. I won't get into this. Professor Neal nicely alluded to some of these yesterday. The effects of hormonal therapy plus radiation, likely synergistic. There's also suggestions and data suggesting improved vascularity and oxygenation with the use of androgen withdrawal and androgen deprivation that makes radiation killing more effective. So let's run through a few of these large trials. Many of them run through the RTOG in the US or the URTC in Europe. So one of the first was 8610, which added, again, in the setting of locally advanced disease, 4 months of androgen suppression to 68 gray of radiation. And indeed, there were very clear benefits as far as metastatic free survival and also overall survival. So 4 months was better than none. The EORTC then extended this by saying, well, what about 3 years of androgen deprivation therapy with radiation versus radiation alone? Sort of the reverse of the Vidmark and the Wardy papers. And indeed, very clear overall survival advantages to long course, 3 years of androgen deprivation compared to radiation alone. The RTOG then asked the question about duration. So at this point, we knew that 4 months was better than none, 3 years was better than none, but what about long course versus short course androgen deprivation? And indeed, RTOG 9202 addressed this, and it compared 4 months versus 2 years and 4 months of LHRH agonist-based therapy plus radiation. And there was very clear metastatic-free and disease-specific survival gains. No overall survival difference to the longer course of therapy, though if you looked at the subset of gleasonate disease, there was a suggestion of overall survival advantage in that subset. BOLA in the EORTC also looked at the duration question, so 3 years versus 6 months of hormone therapy, along with radiation. And in fact, there was inferior survival in the shorter course androgen deprivation arm. So it appears that 3 years was better than 6 months. In the RTOG protocol that I just showed you, 2 years, 4 months was better than 4 months. So longer seemed better. So this sort of summarizes that. In locally advanced disease, we know hormones alone are inadequate without radiation. 2 large randomized trials. When including radiation, 4 months of ADT is better than none per RTOG, 36 months is better than none per ERTC, 24 months is better than 4 months, and 36 months is better than 6 months. So a lot of studies looking at this, a lot of large randomized trials. And I just want to point this one out that it's not published yet, but you'll hear more and more about. It's been presented at ASCO GU and other meetings, which is the PCS Force trial, which actually compared 18 months and suggested that that might be as good as 36 months. So I think in the future, right now, standard of care is long course, 2 to 3 years based on the RTOG and ERTC trials. But I can see practice changing to ease back a little in the future. Perhaps 18 months is sufficient. Won't get into this much. I addressed some of this yesterday regarding dose escalation. Just important to note that a number of these trials did include advanced disease, T3, T4 disease. And the bulk of the data suggests that indeed there is a benefit to dose escalation, probably in all risk groups, and both low risk to high risk in advanced disease. So I made this point yesterday regarding a 10 to 20% freedom from biochemical failure benefit for a modest escalation in dose of about 8 to 10 gray. And I do believe that that should be done also in locally advanced disease. One of those trials was the Hamilton study that also looked at locally advanced cancer, node negative, and was using a brachytherapy boost in addition to radiation as a means of achieving dose escalation. And with good follow-up, very clear benefit as far as biochemical control and also survival to the addition of a brachytherapy boost for dose escalation. So to follow us on the prior talk from Professor Neal, what about irradiating the lymph nodes? A number of nomograms are out there to estimate the risk of lymph node involvement and therefore whether or not one needs to address them with radiation. We learn a lot from the surgical series and the surgical mapping studies as to where indeed these nodes lie. And we all know that the external and internal iliac, or the external iliac and the obturator region is the most common, internal iliacs as well. But periaortics are not that uncommonly involved, though surely with radiation we can't chase nodal fields that high. So when it comes to radiation, which field do you expect to yield better results? Is it the yellow one that treats prostate? Is there a limited pelvic field? Or is it the standard pelvic field that typically would go up to bony landmarks like L5S1? Which one should yield better results? You would assume the larger field, just given the distribution of where lymph nodes tend to fall in the surgical series. So as is shown there. And indeed, all of these large trials, many of which we just discussed, did use pelvic radiation, addressing the lymph nodes as well. However, one of those studies, RTOG 9413, that was its primary goal, was to look at whole pelvis versus prostate-only radiation in the setting of high-risk disease. And with long-term follow-up, there was absolutely no difference between the two. It was a negative study. At first reporting, there was a suggestion of benefit, but with longer-term outcomes, that was washed away. So, and if we look at some other studies, including the intergroup trial that I showed earlier, the Wardy paper, there was an exploratory analysis done within the hormones and radiation arm, and they looked at those who were treated with pelvic fields versus prostate-only fields. And indeed, there was no benefit to the addition of pelvic irradiation in terms of overall disease-specific survival. There is, in my field, in radiation oncology, there's two camps. There's Mac Roach from UCSF, who will treat lymph nodes for everyone. There's Anthony D'Amico, who won't treat lymph nodes for anybody. And it's sort of the interpretation of the data. But we have to admit that the data to date has been actually negative, though in our heart of hearts, many of us think there probably is a good role for pelvic irradiation for the right patient, and I would say that that's more my practice and my group's practice, which is selective treating of pelvic nodes for the higher risk and younger patients typically. There's this RTOG trial, which is currently occurring, that is hoping, again, to answer the question in a cleaner fashion. When treating lymph nodes, we have to remember, just getting to yesterday's talk and the evolution in technologies, it used to be the 4-field box. It means that all of this within the red square would be treated, and as you can see, a lot of small bowel. This is where a lot of the toxicity comes from our treatment. I mean, here's a good example of just loops of small bowel that are being exposed to at least 45 gray of radiation. However, here is a true benefit for IMRT. IMRT can absolutely sculpt and treat the nodal basins and avoid central lying structures such as small bowel, the bladder, etc. And so I think that here is really an advantage for technologies like IMRT. And going back to yesterday's talk as well, where I showed you some modern means of image guidance and localizing the prostate. There's ultrasound, cone beam CT built into machines, daily imaging of the prostate to find it and to be accurate within a millimeter. And indeed, there's even the GPS transponders, these little beacons that you put into your prostate, real-time tracking motion of your prostate during treatment, and so that your wife will always know where you are. But here's an example of localizing to the prostate radiation, addressing the pelvic fields and pelvic lymph node basins. But what happens if you indeed change your localization based on your prostate, and you can see you could actually, in fact, miss your nodal basins by doing so. So this is just a technique, a technology, or a phenomenon that needs to be addressed somehow by your radiation oncologist. One other thing, and this is it's always good to look critically at your own field as to variability in practice. So the question here was, 2 cases were given to 10 or 12 expert GU radiation oncologists and said, contour the pelvic lymph node fields. And indeed, there was great discrepancy between these experts. For case 1, the minimum volume drawn by one was 80 cc's over 800 cc's by another. 10-time difference as well. This is extraordinary. The mean volume was, as you can see here, there was only total agreement in 17 to 30 cc's between the 12 expert radiation oncologists. And if you actually unified the outer boundaries of all the volumes drawn, you could be well over a liter of tissue. So this, in fact, and here's just an example, each colored line is somebody else's rendition of where the pelvic lymph nodes or how one should contour them. So there was indeed significant disagreement, and this led to a consensus building for trials that was led by the RTOG. And indeed, I think that has helped standardized lymph node contouring and how and where we should be addressing, including going as high as the common iliac and addressing some of the presacral region. Again, the external and internal iliacs and presacral regions. Here, external, internal. Similarly here, and as soon as one gets to the femoral head top, one comes off of the externals, inguinals are very unlikely to be involved in addressing also the obturators. And I'm actually on the closing slides, although they're a little messed up. But yeah, thank you. So, how can we summarize everything that I just showed you? Well, in fact, external beam radiation and hormone therapy is effective treatment for high-risk locally advanced disease. A lot of large studies have proven that point. Improved survival, there are favorable toxicity profiles. I'm going to be, this little messed up parenthesis statement is really to be provocative to this audience, which some in my field would say, should this not now be the gold standard for the treatment of high-risk locally advanced disease, external beam plus androgen deprivation, against which other interventions should be compared, such as radical prostatectomy? The question is, where does the level 1 evidence, comparative level 1 evidence lie? And I would say it's been a credit to those who've been doing the radiation and hormone therapy trials to have developed that type of high level of evidence. I'm not saying I necessarily believe that. I actually do believe in surgery for high-risk disease as well for the right patient. However, it's just to be provocative and to think about that. So we'll need to see how practice patterns change. We see that large randomized trials don't necessarily lead to the adoption of those practices as the capture database shows. I think it's definitely our responsibility to know what we're treating. If we're doing surgery, as Professor Gaston showed beautifully, how to do that technique well. And I think that the role for pelvic nodal irradiation, radiation dose, the duration of hormone therapy, for example, I showed you 18 months might be enough. The extent of androgen suppression, meaning there are trials that are ongoing that are adding on total androgen blockade, such as RTOG 115, which is adding on TAC 700 to androgen deprivation and radiation. Those trials are ongoing. There are trials being looked at in enzalutamide as well. And indeed, there's some trials that have yet to report that have even added on docetaxel chemotherapy in addition to androgen suppression and radiation. So I think that the extent of androgen suppression, the addition of these more aggressive systemic therapies to radiation and hormone therapy really do await these trials, and I think you'll see these trials reporting in the relatively near future. Thank you.
Thank you very much. Exciting state-of-the-art radium where we are with radiotherapy. Can I just ask the interesting parallels between the radiotherapy series on lymph node treatment and what we heard about surgical lymph node treatment? And I wondered, if I were to ask you, do you think that the extended lymph node dissection would be comparable to hormones plus irradiation of the lymph nodes in men with high-risk disease? What do you think?
Yeah, no, I mean, I think so. I mean, clearly, in general, we're talking most of the time clinically negative disease. And so this is microscopic involvement of the lymph nodes. And I think that radiation at the doses of 45 to 50 gray, which is usually the range that's used for pelvic irradiation with hormone deprivation, is likely as good of addressing micrometastatic disease in the lymph nodes. The issue is that our fields are limited somewhat. We can't chase it up perhaps as high as you could do an extended pelvic lymph node dissection. So the radiation only works where you point the beam. So I think that is a potential limitation. But, you know, I think in node-positive disease, it's a tough state. And I think that there's reasonable evidence supporting extended lymphadenectomy and reasonable evidence from some of the trials that I showed you. Some of the trials actually did have node-positive disease and subsets of patients with node-positive disease, and the survival advantages did hold in a number of them. So I think radiation and hormones can be effective.
Any other questions? Wow. Yep. Simon, got a microphone? Oh, sorry, Damien. You had the microphone. You go first.
Well, thank you very much for that talk. My name is Damien Green from Sunderland. There's a couple of points I'd like to make, especially about high-risk patients, radical prostatectomy versus external beam hormones. And the points are really about hormone deprivation and localized prostate cancer. So first thing is, a proportion of men who have 36 months of hormone deprivation will remain permanently castrate. The second thing is, if you have a patient who has a localized treatment, external beam with hormones, and has a failure at 36 months, you're not talking about local treatment failure, you're talking about hormone escape prostate cancer, which is a very different thing. And the third point is, apart from all the side effects of hormone deprivation, which can be really serious, if you use up what is your best last chance of treating systemic prostate cancer as your first line of defense in a young patient, it really, it's a kind of I think an area we haven't really explored enough. And I would say back to you, the counter argument would be, where there's no level 1 evidence, surely we should be using the treatment where we're not using hormone deprivation as first line.
Yeah, I mean, I see your point. Look, I think the advantage to radical prostatectomy in localized high-risk disease is that you might get away with it, and that might be all that you need. And I think that's very attractive. And I mean, I will tell that to patients that I see as well. And the side effects of hormonal therapy are not trivial. There's no doubt about that. The flip side is, in certain high-risk disease and locally advanced disease, surgery isn't all that you're going to need. And that's going to be followed then by radiation and hormone therapy often. So the flip side argument would be, well, why do the surgery then? You could have gotten away with just the hormones and radiation to begin with. So I think there's a good argument to be had. I also don't think that necessarily, side effects of hormonal therapy can be horrific, there's no doubt. And long-term suppression can lead to lifelong suppression. I agree with that. However, failure of hormones and radiation doesn't mean that you're necessarily castrate resistant. You surely can come back and explore androgen deprivation, LHRH agonist based, again, even in the setting of failure there. I take your point, though. I guess the one thing would be is we should then develop that level 1 evidence. I think this is an area that is actually begging for it.
We need to move on. Simon.
Yes, Jason, difficult cases like fit patients who've got 1 or 2 positive nodes on a scan, maybe locally advanced disease. You talked about pelvic IMRT and not much evidence for that. We've got some patients coming in and asking about the very cleverly named cyber knife. Could you just give us a short comment on that?
Yeah, well, I mean, so cyber knife is typically a means of ultra-extreme hypofractionation, delivery of treatment in, let's say, 5 fractions, all right? Typically to the prostate, most of the time used in localized lower risk disease. There's data from the Italians looking at hypofractionation, moderate hypofractionation, not with cyber knife, with IMRT or any of the other available techniques, suggesting a potential benefit in high-risk disease, or at least equivalence. Or the suggestion of equivalence. So I think hypofractionation could be used in high-risk disease to address the prostate. Your question about the lymph nodes, well, that's an interesting question. The issue is oligometastatic disease. And where does prostate cancer fall into that realm, such as, for example, oligometastatic renal cell, where we know we should be more aggressive in that site of metastatic disease? I think prostate cancer is different to renal cell, and it's very unlikely to be present in just that 1 or 2 nodes. So I think being locally aggressive with cyber knife, hitting that 1 node, SBRT, very high doses of radiation is interesting, but I don't think anybody's proven that it leads to benefit. That being said, I think the move towards being more aggressive in the setting of oligometastatic disease is part of the future.